Welcome to the new year of 2025, to a new year of lessons from the lab. My name's Devin Rubin from Mayo Clinic in Jacksonville, Florida. Enjoy this episode. Welcome to another episode of Lessons from the Lab. It's 2025. It's January. It's a new year for lots of things and for a new year for these A&EM Lessons from the Lab. And it's wonderful to have a great first guest of 2025, Dr. Michael Munin. Hi, Michael.
Devin, great to see you. I'm so honored to be here. I wore my special A&EM sweater just for the occasion.
That's perfect. I have my A&EM undergarments on, but I'm not going to display those during this episode.
It could be spicy if you did.
That could be for a different kind of YouTube video, right?
True,
Yeah.
true.
So Dr. Munin is a professor of physical medicine and rehabilitation at University of Pittsburgh. I assume you're in Pittsburgh right now, where it's nice and cold and chilly.
It's about 5 degrees, going to -12 tomorrow morning.
Yeah. Okay. So it's better to be in Jacksonville, Florida, where it's 32 degrees tonight, and which is cold enough.
That's cold. Yeah, that's still cold.
It's a perfect day to have a podcast or a video, and we should be by a fireplace, and it should be a fireplace chat, but we don't have fireplace.
We can put that background. They have backgrounds of fireplaces, for those watching on YouTube, they can see our virtual fireplace.
Yeah, if you're watching this now and it's cold, then make sure you're by the fireplace in your home. So
there you go.
So it's 2025. Has it been a good year, or we're a couple weeks into it? Has it been a good year for you so far?
I mean, so far we're still early in the year. I have some travel coming up, but yeah, so far it's been a perfectly great year.
Do you have any resolutions related to EMG for the year?
Wow, resolutions. I don't think I have any specific resolutions. I think I just always ask myself, just try to stay focused. I've been doing this for 32 and a half years. And the one thing that I have to always challenge myself is to not get into the rut of just doing it. Keep it fresh. Really think about things. Don't let it get rote. I have residents and at times fellows with me, so that kind of keeps me on my toes. So that's helpful. But I think those are my main things I say to myself relative to maybe a new year.
Yeah, I think that's great. I mean, that should be a resolution for every year, the same one, because I think you're right. We're very similar. We've been doing this for a long time, and it is easy to just get into that regular routine. And
yes.
I find, to that point, some days after I've done single fiber EMG, I don't know if you do single fiber, but when I do it, and then I go to my next patient and do a routine needle examination, I feel that it in some ways resets me, because sometimes a routine needle exam is a little bit more rushed, and it just makes it a little more deliberate at times. And it's kind of like taking a deep breath and stepping back and taking our time.
Yeah, no question. And I don't do single fiber, but I have those same feelings when I have a very complicated, let's say a trauma patient, and there's so many, where the localization is, what's the plan in terms of surgical nerve grafting, and really the surgeons are relying on what we say, and having some we've had some really fascinating cases come through recently, and that's always wakes you up from perhaps what's the more bread and butter diagnosis that we would typically see.
Yeah. Yeah. Well, speaking of that, that's a great segue. I have a fascinating case that I'd like to run by you.
Okay. I'm all ears. I'll do my best. I can't promise, but I'll do my very best.
Well, I never promise. Every patient I see, I never promise anything. So, but I think it'll be interesting to get your perspective on this. And as you may know, and listeners and watchers may know, one of the goals of this Lessons from the Lab is to learn from each other, try to teach everyone who's watching this something that may be useful in your practice, in how you approach patients. And what I've learned over the last couple of years doing this is that many of us are similar, but there are different ways to approach cases and different ways that we think about it. And I always learn when I'm doing this. So I look forward to learning from you, Michael, with this case. So I'm going to put up a couple slides here. Let me just share my screen. And this is the hardest part, is getting this all going. So, okay.
Should we tell the audience, I've not been prepped. I've never seen this before. So
That's right. This is, yeah. So this is like a board exam. I always say it's not a board exam. It's not an oral boards, but yeah, these, as with every lessons from the lab, the guest, the expert doesn't know anything about this case. So basically, so the cases that this is a case I saw a couple years ago. And the gist of it is, it's a 67-year-old man who presented to the EMG lab for evaluation of speech difficulty, which he had had for 6 months. And basically, he had had several years prior to that of dysphagia that was progressing to the point where he was aspirating and required a feeding tube placement 5 years before coming for the EMG. So it was really bad. And then 6 months prior to the EMG, he started having voice difficulties, and he was becoming more hoarse, and that progressed to the point where his voice was almost completely lost. And he had no other symptoms. So arms and legs were fine. He had no diplopia, he had no ptosis. It was just this progressive dysphagia for 5 years, and then losing his voice, hoarseness of its voice. So not giving you a whole lot of information, but just if with that information, what, I don't know if you've seen patients like this, but maybe when we all get a history and our mind starts to think about possibilities, and what goes through your mind when you hear this story?
sure. So I have a couple of thoughts with this. So what's interesting is that we have dysphagia that precedes hypophonia or dysphonia. And so that's important because typically when the recurrent laryngeal nerve is involved, we see voice disturbance. And when there's indirect laryngoscopy or direct laryngoscopy, we'll see a unilateral vocal fold paralysis. When there's dysphagia that predates that, one has to understand that that could be a sensory dysphagia. Typically, the superior laryngeal nerve, the external branch of that, excuse me, the internal branch of that, supplies sensation of the larynx. And so it could be something along those lines. Or less commonly, you can have pharyngeal sphincter neuropathy, but that's usually, maybe there's some myopathies that can present that way, but that's really a very uncommon thing. So so the fact that we see dysphagia for several years and then hoarseness is just unusual. And then the third bullet is kind of crazy in that there's nothing else going on. And so if you're thinking about maybe a neuromuscular disorder such as ALS, that doesn't seem to be affecting that. There are some myopathies that can affect the laryngeal muscles. I guess that's possible. That doesn't really affect or minimally affects the limb weakness. And of course, there's central things like strokes can do this. So a brainstem strokes can sometimes present this way. So that's the other thing I'm thinking that would be on my mind. But I need a little bit more information. You've picked my interest here, but I feel like I'm a man on an island right now.
And I guess I mean, obviously from a stroke standpoint, first of all, this is an EMG lessons from the lab, so I'm not gonna present a stroke. But also, this was progressive. It wasn't really sudden onset, right? So let me ask you. You mentioned say again, which branch supplies sensation to the larynx?
It's the internal branch of the superior laryngeal nerve, and the external supplies the cricothyroid muscle.
But patients aren't going to complain of anything
No,
sensory wise, because of, yeah,
correct,
you don't feel
correct.
that
You don't
consciously.
feel that, but that's a big cause of dysphagia. If you can't feel the bolus of food in your mouth, as you do in the mastication and forming the bolus and try to swallow, that is a cause of dysphagia from a neuromuscular perspective.
Okay. Yeah, good. So what other information do you want?
Well, I do think that, certainly examination is always good, but you kind of said no complaints. So I think kind of a focused laryngeal examination would be helpful. Is there unilateral or bilateral vocal fold paralysis? That would be very, very important to know. Is there paresis, which means that the vocal folds move, but they're weak? Um, is there things like stridor, where the vocal folds are together, or kind of a discoordination? There are dysphonias that can be involved here. So all of those things would be useful, and certainly the other bulbar cranial nerves. I mean, the recurrent laryngeal nerve and the superior laryngeal nerve are branches off the vagus nerve, which of course comes from cranial nerve 10, and there are other cranial nerves involved with swallowing. The hypoglossal nerve would be one. Certainly cranial nerve 9 as well. So I guess some element of a cranial nerve examination would be useful here.
Okay. And from the laryngeal examination, that you can you do that clinically in the office or through ENT?
That's usually going to be ENT is going to
Yeah.
help us with that.
Yeah. I mean,
Yeah.
I was going to say, I'm impressed if clinically, you with your reflex hammer and hands, you could do that.
No, no.
Yeah.
But
Okay.
but 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 we do our laryngeal EMG in the same office concurrently with our voice laryngology colleagues. And so we have at University of Pittsburgh, we have this really cool voice center where electromyography is embedded within the voice center. So we're able to do those things same visit, same day.
So when you do that, just out of curiosity, are you doing, is one first? Do you do the laryngoscopy first and then
Yes,
EMG, or yeah?
yes. Using laryngoscopy first, and then based on what we were seeing, then that helps to guide what the EMG question is going to be.
Okay. Okay. So you're not just blindly sticking needles in and, kind of doing that and then saying, now let's look where the needle is.
Well, that's a little different thing. So in terms of doing a little advertisement, we just published a muscle and nerve. Myself and Libby Smith, who's a laryngologist I work with, it's kind of the electrodiagnosis and the utility of laryngeal electromyography. You can get it right now in January. It's on the muscle nerve website, but it'll be published in a special edition coming soon with articles that are kind of a PM&R focus that Zach Simmons, myself, Larry Robinson, and Tom Miller are putting together. So look forward to that in the future.
Yeah, I saw that. I saw the first article you mentioned. So yeah, I haven't read the whole thing yet, but I knew it was recent.
Yep.
So good. All right. So I'm going to give you the neurologic exam here because obviously that's important for anything we do. We should always be examining patients. And so this is the brief neuro exam. So there was no dysarthria, but the voice was hypophonic. That's how it was described. And again, this was a couple years ago. Facial muscle strength was normal. All the facial muscles, there wasn't any obvious weakness, but the tongue did have atrophy and fasciculations on the left side. And then the rest of the exam was normal. Sensation to the face, ocular movements, limb exam was all normal.
So
Palate, I believe, I don't remember specifically, but I believe that was normal, palatal rise.
all right, so that tells us that cranial nerve 9 is okay, but certainly we have some cranial nerve 12 involved. And what's interesting here is that it's not the entire tongue. You're describing the left tongue, the left side of the tongue. So that would be certainly it could be seen in motor neuron disease can present that way. But we do see, and did this patient have any history of head and neck cancer radiation, by the way?
Well, funny you should ask. Why do you ask that? Yeah.
Because
Is
you
there a
can
paper
have,
about that, I think?
there is a paper about that. We published it on like last year on a cranial nerve um, 12 hypoglossal neuropathy. And yeah, have you read that article? Have you seen that article?
I have seen that article. And this patient actually did have tonsillar cancer. Uh, so obviously a medical history is important with any patient too, that which I held back at the beginning, but had tonsillar cancer in 2004, had radiation, and has a bunch of other general medical problems.
Yeah.
So that's important information, right?
Hugely important information. Hugely important.
Yeah.
Huge.
So knowing that, what do you, I mean, kind of what do you think?
Well, now I'm thinking, certainly the dysphagia may not be a sensory dysphagia. It could be an oromotor dysphagia, in that because the tongue isn't working well, he's had radiation. You can get this. Some people call it like a radiation myopathy, kind of a like this just diffuse fibrosis that can affect the field. And it was 2004, which is an important thing to remember as well, because radiation doses were higher and the mantles were bigger. I'm not an expert in this, but what I do know is that they've gotten better and more precise and less radiation over the years. And so, if a nerve is involved in that field, a late onset radiation problem can give very specific EMG findings, which I think somebody published a good article on myokymia and boy, who was that person? What group? I forget who did that. Um,
Yeah, I think there's a couple people on this call that have published about myokymia. So
yeah, yeah.
yeah, but
So I
let
think
but oh, go ahead.
no, so that be some of the things I would be thinking of, but I think um, so the main things here is I'm now concerned that we've been looking with a focal hypoglossal neuropathy, that a post radiation. And the other thing you have to worry, of course, with cancer also is a recurrence of cancer, and so
Mhm.
certainly some imaging to make sure that that's not the issue. And so that's going to be paramount. The fact that it's been so long and so slow growing makes that less likely, but not impossible.
Yeah,
And the only thing we haven't really explained yet is the hypophonia. Of course, radiation can affect the recurrent laryngeal nerve, and so I still want to know what his vocal fold mobility is, because that would help me think about if the recurrent laryngeal nerve is involved. But I'm really hot on the trail of the hypoglossal neuropathy.
yeah, and I guess the question or a point would be if someone has, and maybe I'll ask you with your experience, and if someone has a severe unilateral hypoglossal neuropathy, do you think their speech would be really severely affected? To me, it would be that, yeah, they may have some dysarthria, but if it's unilateral, half their tongue's still working, other facial muscles are working, they shouldn't be severely dysarthric, or here it's more hypophonia. So
Right.
that's
Totally,
discordant with just one unilateral hypoglossal nerve.
totally agree. Yeah, dysarthria, I'd be happy. I would understand that. But the hypophonia is not from the hypoglossal nerve.
Mhm. Yeah, okay. So because this is in part an EMG lessons from the lab, if this patient presented to the EMG lab, into your EMG lab, what would you do? How would you approach this patient from an electrodiagnostic standpoint?
Right. So certainly, I would definitely want to needle the tongue, and one of the things that we kind of have started to do is using ultrasound guidance for this EMG placement. So you can kind of see where the sublingual gland is. You can kind of see where the arteries are. Make sure you're deep to the mylohyoid and not and away from the digastrics, and to get to the genioglossus that way. So, and you can do left and right. And so I definitely would want to do that to confirm and to look for, is this a neuropathy that has acute denervation? Is there partial meridian recruitment? Are the myokimic potentials at rest? And so those would be the things I would want to see. And I also want to compare it to the right side to see that there was a side to side difference. And if I was concerned about voice, it's real easy to do cranial nerve 10, and that's the thyroretinoid muscle. That's a main adductor from the vocal fold process. You do it right here in the cricothyroid ligament. And again, if you look at our paper that I talked about, that's on the website Muscle and Nerve. We have good diagrams and just how to do it. It's easy to do. It's not a big deal. A little bit of training. We have workshops A&M that can show you how to do it if you've never done it before. But I would easily want to do that and the hypoglossal EMG. And then because everything else appears to be normal, I certainly might do a minimal standard workup just to make sure there's nothing on the limb and such, that I wasn't missing anything along those lines. And I think that would give us a lot of information. I could also do another, like a facial nerve, orbicularis oculi, if I wanted to check another facial nerve,
Mhm.
another cranial nerve, excuse me. But there's nothing by history that says that that would be an important thing to worry about at this point.
Yeah. And out of curiosity, have you ever had a patient where you've recorded myochymic discharges from any of the laryngeal muscles?
Yes,
Okay.
absolutely.
Okay. And
Yeah.
were they pretty typical? I mean, burst typical, or was anything unique about them? I know there's not a lot of room in those muscles and
In fact, we actually published a case report on this, on laryngeal myoclymia.
hmm,
Um, I forget how long, it must have been in the early 2000s.
mhm.
I'm blanking on I have to look at my CV to figure that
That's
one out.
but no, but yeah, so and it was someone with radiation, I assume. Or no?
No, it was
Really?
not. I believe it was, I want to say someone with maybe MS or some kind of
Oh,
tumor.
okay.
It was not that. And again, I'm gonna have to go and look that up real quick after this podcast is over.
To remind yourself, you have too
Remind
many.
myself.
Yeah. And you know, the point is that not all myokymia comes from radiation. And in our
Absolutely.
series that you alluded to, our series of patients with myochymic discharges, we had 35 that had radiation and 35 that never had radiation. There were all sorts of mononeuropathies and even some radiculopathies that were associated with just a single myochymic discharge. So I think you're right. You know, in the context of a history of radiation, if you have myokymia discharges, it's the radiation.
Yes.
But yeah, so okay, good. So I'll just tell you, I'm not going to show you everything. We did do again. This was a while ago, but we did do some conductions and a few needles in the limbs. I think he had a little bit of neuropathy in the conductions, and we're not going to really get into that. But from the facial standpoint, I'm going to skip ahead and we did a facial motor. And
Mhm.
for some reason, I'm not sure I would do this now as I think about it, but we did, or the techs at least initially did some repetitive nerve stimulation of the facial. And I think with what you've said, and I agree that that wasn't really the concern, but sometimes when someone presents with dysarthria, that's often something that we'll check.
Yeah.
Um,
I
so
I have no problem with it. Just showing that that's normal.
yeah. And then I'm going to show you two, hopefully these will play a couple clips from the genioglossus of needle EMG.
Okay.
And hopefully you'll be able to hear these. So here's one. Can you hear that a little? See it a little?
Yeah, I can. I can.
And this is the same, probably just moving the needle a little bit. So a little, I won't play it all, a little distant to those, but what do you think?
So they look like they're pre-junctional oriented potentials because they're somewhat irregular, but they're kind of grouped firing. Um, Not the most classic myokymia I've ever seen. One of the things we like doing is really changing the sweep speed to maybe 100 milliseconds per division, and really compressing it to see the groups of potentials. These seem more individual rather than groups of myokymia potentials together. And they had a kind of a muted sound,
Yeah,
not as much as the classic marching soldier sound that I
yeah.
would typically hear.
And I think that's a good point that, you know, we teach, and I've done this for years and say myokymia discharges classically sound like marching soldier, but they don't. Some of them do. It depends on the inner spike interval, the frequency of the bursts. And these are, I agree, these are longer. There's voluntary motor units here too, but these are these kind of longer and they're distant. The needle's distant to them.
Yes.
So we don't hear it very well, but there is this kind of long burst and it stops and then long burst again. And I think you can see it, hear it a little bit better on this one. I'll play it again for those of you who are listening right there.
There's that unit that comes through that's a little confusing. A voluntary motor unit that comes through.
Yeah, it's that kind of stuff right there, right here.
Right,
See,
right there. Yep. Yep.
you could see the same potential there that comes and then stops. So, yeah, so that I agree. Those were we thought
And
the
I think compressing the time base would be interesting. Have you done that? Do you do that much
I
when you're
always do. I don't know why when I took this clip for this episode, I just played it this way because most people look at the units this way. I usually use a 1 second sweep, a 20 division sweep. So
yep.
it's much easier to see that bursting. So I'm showing it the way I don't look at it usually.
Uh,
And then one more, just this is more the voluntary motor units from the Genia Glossus. It's a name that tune because it's a quick clip, but I'll play it again. So I don't know. What do you think? I know that's hard. It's one spot, but do you think those are really abnormal or not too bad?
I do. I think I saw some polyphasicity and some decreased recruitment and rapid firing is what I heard. The
Mhm.
change of pitch. And I saw some polyphasic configuration going through quickly. So it appears definitely neuropathic to me. Amplitude wise looks reasonable at 200 microvolts per division. So the units are appropriate size. They're not large amplitude potentials.
Yeah,
Duration hard to see on a quick.
yeah.
But the auditory change of pitch with the polyphasicity I thought was apparent.
Yeah, and we thought so too. This is hard to see, but this is how this is how we graded. There were a few fibrillations that I didn't show. There was reduced recruitment. And I think maybe the grading of the size wasn't too bad. And then there were the myochymic discharges. And this patient also, we did a mentalis. So you mentioned doing a facial muscle, and there were some borderline big units in that as well. So not a whole lot was done. I mean, I think in this case it was fairly obvious. I don't do laryngeal EMG, so that was not done. I know you would have. I think that's a good
Yes,
idea, but the
absolutely would have.
patient did see ENT and had laryngoscopy and showed that there was decreased or absent activity in both bilaterally there. This is just part of the report there.
So this is where laryngeal EMG is very helpful because that could be he's 67 years old, so there could be some age-related atrophy of the vocal fold process. There could be some radiation myopathy where things are just fibrosed and not moving well, or there could be a focal neuropathy, either unilaterally or bilaterally. And so really EMG would help us determine that. And then if it's just radiation, and let's say the EMG is normal and it has radiation, then there are some, gliding and other types of exercises things. There's um, 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 injections of kind of a bulk agent, for lack of a better term, that the laryngologist can use to kind of bulk up the vocal fold. Remember, the fold is the mucosa around the muscle that kind of the muscle powers the vocal fold, and the folds are what come to midline to vibrate and produce speech as air flows up through them.
Mm-hmm. And in this patient, and I don't have the answer because we didn't do it, but what would you have expected to find on, on laryngeal EMG?
You know, I would. I'm assuming that there was some radiation involvement of the laryngeal area and perhaps even a laryngeal nerve. So I wouldn't have been surprised to see some myokymia perhaps at rest within the thyroidnoid muscle. I wouldn't be surprised to see neuropathic stuff or even myopathic if there's some muscle change where the nerve is spared. So you
Can
know
so again, my ignorance of not doing this, how difficult or easy is it for you to detect a myopathy in the laryngeal muscles on needle EMG? Because aren't the motor units normally very short duration?
they're usually short duration, but the amplitude usually is reasonable. And one of the things that we love to do is turns to amplitude
Okay.
measurement. And so, if I can just briefly explain that, it's software on every machine. Almost every modern machine has this. And so what you do, and what the cool thing with laryngeal stuff, unless they're in severe pain because of the needling, which isn't typical at all, it's kind of an all or none. Patients, when they vocalize like an E or a, bear down, when they bear down, they have a valsalva and the vocal folds move together. All A large portion of the available motor unit pool is activated. It's hard to just do 1 or 2 units, like a conditioned athlete can do with the limb muscle, for example. So that if you do this turns amplitude program in most of the EMG machines, you can get this normal envelope. And all you do is, as they're phonating every like 4 or 5 seconds, when you have a good needle rise time, you hit a button and it just captures a segment, and that segment is analyzed. You do like maybe 5 or 6 time points. You can do various amounts of, how loud they can do a low or a louder sound, and you get this a nice envelope, and you get little dots of where the machine has analyzed the turns, meaning the recruitment and/or the phasicity of the units versus the amplitude, which is self-explanatory, just the size of the units. And then what you can see on this normal envelope, we actually produced a normal envelope for the thyroid muscle.
Mhm.
If you have points that are up outside the cloud, that's neuropathic recruitment,
Mhm.
and because of a large amplitude, kind of low numbers of units. But on the bottom of the cloud, if you have a lot of turns but not so big amplitude, you can actually see this and diagnose neuropathy. It helps myopathy, pardon me, from this turns to amplitude curve. And so it's really cool software. It's available on all machines. It's easy to do, and we find it very, very helpful. In addition to the standard electrodiagnostic procedure of evaluating motor unit potentials.
Right. And I think the key is you have you have normal data, reference data for that envelope. So
Yes, yes, we do.
because you have to have that, of course, right? And
I have to have that.
yeah, because otherwise it's, you don't, it may fall down. It might look like it's myopathic if it were a limb muscle, but for
Yes,
the laryngeal muscle, yeah,
yeah,
it may not be.
yeah.
So,
We
okay.
we we published this. I think we've given it to all the manufacturers, so that normal cloud is out there.
Yeah. Good. Great. Um, So you think this is radiation induced? We don't know about the laryngeal muscles, but the tongue. And is it unusual? Last question. Well, maybe last question, but that it's been so long for the tongue, like it's been, I forget how many years for this to be affected after
Yeah, no,
radiation.
no,
Yeah,
it's actually quite normal. In our study, I think the earliest we saw was maybe like 2 years out, but a lot of our patients were 10 or 15 years out. And so it's this gradual process of fibrosis that this does not occur acutely.
yeah,
And so this is totally in line with what we would see clinically.
yeah. I think this is the study that I did read.
Yes, this is it. That's
Yes.
it.
So you had, I think, 13 or 15, you have 10 patients in this that had unilateral tongue immobility. And this was recently,
Recent,
a
recently,
couple of,
yeah,
yeah.
yeah.
So,
Randall is an ENT resident now, I think, at Hospital University of Pennsylvania. Jonas Johnson is a leader in head and neck cancer. He's the chairman emeritus here at UPMC Pitt. And Marcy is a nurse researcher as well. So they run
yeah.
the survivorship clinic for head and neck cancer.
Wow. Terrific. And yeah, no, this is worth reading for everyone watching this. It's a great article. I think the mean time from radiation in these patients was about 13 years.
Yes,
The
there you
mean,
go.
yeah,
There
yeah.
you go.
The one interesting thing, this is not a journal review, I'm not going to go into detail. You go through all the patients but what I found was interesting, I'm going to just stop sharing, is that there were 3 patients out of the 10 that the needle examination did not show abnormalities in unilateral tongue weakness. I don't know if you remember that because it's been a couple years. No myokymia, no fibrillations, and I think no reduced recruitment.
Right.
And how do you explain that if their tongue is weak, but
I think that's fibrosis, that the
okay,
tongue literally can't move.
Yeah.
it's bound down. It's think of cementing. It's not cement, obviously, but think of that type an analogy as to why things can't move in that setting when there's normal electrophysiological functioning.
Yeah. Now, staying on that point, you mentioned a really good instructive point that I'm going to utilize in my practice using ultrasound to needle the tongue and look at the level. So do you always needle the tongue from underneath, or do you ever go directly into the genioglossus?
Always underneath, never that
So
way.
could it be possible in those cases that didn't show findings that you just weren't in an area that was affected?
Certainly,
I
that's
mean,
certainly a
anything's
possibility.
possible,
Yeah,
but
yeah,
right,
yeah.
right.
But we felt pretty good about localization. But you're right. Could I maybe the pocket we sampled wasn't a pocket of denervation? Couldn't
Yeah,
exclude that
because
fully.
I think it for me when I'm needling the tongue, and I do it both ways. Sometimes I'll go in it directly in. It kind of wakes patients out a little bit when they see a needle going in the tongue. I tell
Yeah,
them it doesn't. It feels the same as any other muscle, but it's the idea of it. But
sure,
if I
sure.
see someone that has tongue atrophy, and I go directly into the tongue, I can stick the needle as long as they're not so weak that I can't grab the tongue with gauze. I can stick the needle in the atrophic area. I know I'm right where the issue is, where in the muscle that's abnormal. Whereas without ultrasound, and one of the challenges sometimes is when you go up, and you alluded to this, you don't know exactly where you're in. You could be in digastric, you could be in a different muscle. So I
And there's
think,
vasculature. You want to make sure you don't hit vasculature or the glands. So it's nice to know what not to hit.
yeah, yeah. So I think that's a really nice point that I'm going to utilize and try that out. And I mean, we use ultrasound for lots of other things, and I imagine it's very easy to stick gel right here and
Yeah, yeah.
look.
Just
Yeah,
the scanner is right where my finger is, like that.
right. Yeah, right. Great. Well, interesting case, huh?
Now that's a great case. And I'm really honored you found our little tongue hypoglossal paper, which is interesting because I think it's the highest number of hypoglossal neuropathies from head and neck cancer ever reported.
Yeah,
So
yeah, yeah. It's I mean, I think thank you for writing these great papers because that was interesting. We don't see it a lot, but it's good for people to be aware of. And then, of course, all of your laryngeal papers and the ones that'll be coming out, I'm sure will be phenomenal. So for those people who do it or are interested in learning, you're the person to learn from. So uh,
thank you for that. We have an amazing team collaboration with our laryngology colleagues, and we've been doing it for, gosh, like 25, 30 years. And we have like, I think 16 peer-reviewed publications as a group. So we've done a lot of sentinel work in the area.
yeah. Do you have you kind of alluded to this, but any advice for someone like me who doesn't do laryngeal EMG? I might be too old to be learning new things. You know, I'm getting more and more gray hair. But for someone who isn't too old to learn something new and they want to become competent in doing laryngeal EMG, what would your advice be?
Well, certainly some hands-on would be helpful. And every year at the ANEM meeting, I do a workshop on this. And so I think that would be if you're going to the meetings and if you're interested in that, I think that would be a really good way of doing it. Again, I keep harping on this review paper that's now out, which has a lot of basic how-to. We show the anatomy. So looking at those, I think that might be the easiest way, or trying to visit people who have experience doing it and maybe watching an experienced practitioner. Um, any one of those three or a combination of those three, I think would get you the skills you need. What's interesting real quick about laryngeal EMG, there's very little vasculature. There's a little venule there that can ooze. We do this all the time with patients with anticoagulation, not a big deal, none
Mhm.
whatsoever. The hardest part is that when you come this way, you're in the submucosa, and at times, depending on where the muscle lies and how the cord anatomy is, you can puncture that. And you get a cough reflex, and again, that's the hardest part from the patient and even the examiner's perspective.
Mhm.
Um, there's really in our 32 years of doing this, we've only had one complication really, and that was a person who had really bad asthma, and we provoked an asthmatic attack. in someone who had really bad asthma. And so they were granted a stay at the ICU for observation for a night, went home the next day.
Right.
Um, but that's you know, I don't know, thousands of cases. That's only one, and that might be one thing I wouldn't do in the future. If someone gives me a history of bad asthma, I might think twice about doing the procedure. But anticoagulation, not a problem, and it's easy to do. You know, it takes, you know, anywhere from 5 to 6 minutes in our skilled hands. I think someone who's new, maybe 10 or 15 minutes. It's not a hard thing to do. Just a little bit of experience needed. Look at the available resources I've mentioned, and like Nike says, just do it.
Yeah. Perfect. I've just added to my 2025 New Year's resolutions, and it's to come to your workshop at the AANEM if I have any time free at the AANEM meeting. And if not, then I'm going to come to Pittsburgh when it's not 9 degrees or -9 degrees, and watch you do this. How about that?
I would love to have you anytime. Please come and visit.
It's a deal. It's a deal. Well, thank you for taking the time. I know, you know, it's kind of you. This has been wonderful. It's great learning from you. I always learn from you when we talk about cases, and I'm sure many people who watch or listen to this will. And I look forward to hopefully seeing you soon.
Well, Devin, thanks so much. It was great, and what a great job putting this together. It was a fun, a challenging case. Thanks so much for having me.
All right. Well, you take care.
All right,
Happy
Devin.
New
See you now.
Year. Bye
Take
bye.
care.